It's my pleasure. Good morning, everyone. So I was asked to start off this discussion of the physician in this session where over a few days we're really looking at how we can be patient-centered rather than physician-centered. But in a way, I think this is hard for us, those of us as healthcare practitioners, because we are our own center. So when you look at this image, the question is, do you see the people in the background as aspects of your lives, as physicians or pharmacists, or are those patients, and the physician is in the middle? And it's hard for us, even those of us dedicated to therapeutic patient education, to not have a view of how we influence our patients and the people around us, many of us directing centers of therapeutic education, because as physicians we do know we're experts in atopic dermatitis. It's been pointed out, we come to each visit with knowledge. We have extended experiences with patients and families, and of course we're the center of our own existence, and it's very easy for us to have a perspective like Ptolemy did. The Ptolemaic perspective of the solar system was that everything revolved around the Earth. He was wrong. And it's hard for us, I think, as lead healthcare professionals to not think that the world is revolving around us. And it takes some work to think of the patient as the center of the solar system, since that's especially what we're looking at today. And there are different aspects of healthcare system, but also health promotion that are part of the patient's journey. And we know that a lot of their influences on their sense of the disease come from factors that are outside of even this diagram of medical utilization. So I know that it's very easy to step back into the role of us in the center. And what I'd like to do is to discuss, there's really two aspects to my talk: the challenges that we face in doing this, to look at some of those challenges. And then I'm going to take a digression. I was asked to do a quick update on what's happening in atopic dermatitis, which is almost a joke because, you know, there's so much material within just the last few months. So the first challenge is that the recognition that our perspectives may not be the same. So here you can see the little diagram. You know, there's one person on one side saying 4, and the other says 3. And I know it's very early in the morning, but you can see that there's, you can have different perspectives. So I wanted to outline challenges, particularly in training. I've been very interested in trying to train general practitioners, pediatricians, other than specialists. I do think that their knowledge of atopic dermatitis makes a big difference. But the challenges of training each other in a center that might be delivering excellent care in atopic dermatitis is really a big one. So one of the challenges is our understanding of the disease. It is changing rapidly, and we have challenges in understanding the development of atopic dermatitis and the course of atopic dermatitis that are really remarkable for us to deal with, and I want to really highlight those because it creates issues. We don't always recognize incremental changes in knowledge and in messaging, but they are significant. In our field, the messaging we're giving to patients now is so different than 5 years ago and 10 years ago. And the audience for training varies in their concern for the disease. So from a physician standpoint, who we're trying to train may have a natural interest or not have a natural interest in atopic dermatitis and eczema. So in terms of the disease being in flux, well, we now understand there's a change in our sense of the epidemiology of the disease. We used to say very high numbers, 80% of eczema presents in the first 5 years. Now we have well-established data sets on later onset atopic dermatitis in childhood as well as in adulthood. And the prevalence of adult atopic dermatitis in many countries is clearly well established at 5 to 10%, 7% in the United States. And we know, many of us who lecture on the disease, that there are these very well-designed studies that have shown the variability in terms of both onset and course of the disease. And at this point, when we're seeing a young child with atopic dermatitis, we can make up a number of the chance that it's going to go away, but I don't think it's really predicated upon a set of prognostic factors or genotype or phenotype for that individual that's going to make that very strong data. So a challenge we have is to be able to categorize what the course of disease is based on its presentation. And I also am very conscious, we were discussing over dinner last night, the challenges that we have in a disease that now has outside interests. I am thrilled that there are new pharmacologic agents that have been developed in the past few years. And I will tell you, there are at least 40 more that are well along the way of development. We'll see if they get approved or not. But these are the interests of our pharmaceutical companies in atopic dermatitis, and that's great. But do understand that it's very easy for there to be an overlap of interests, but sometimes not necessarily so. So I do think that obviously our most difficult patients have moderate to severe disease, but we shouldn't forget the work we have to do in training patients and families with mild disease, even though right now there's a lot of emphasis on the more severe disease, because that's where a lot of the drugs are being developed. Other challenges in training, I said, is to highlight the changes in messaging. So recently, before the American Academy of Dermatology meeting, they were due for an update in their written brochure. We've discussed that written brochures aren't necessarily state-of-the-art anymore. And they sent out the brochure, and it was amazing to me. The brochure had been out, it had been a decade before. And reading through the brochure, it really brought home the changes in the messaging, because inherent in the words that were being used was the sense that for pediatric eczema, you should use moisturizers and they'd probably outgrow the disease. That was the sort of main message, which is very different than most of what we say now, which is that, yes, we use moisturizers, but if there's inflammation that's not controlled by good skincare and moisturizers, we use anti-inflammatories, and we're looking for long-term disease control. And so the verbiage sense, this is the verbiage in the brochure, was eczema tends to come and go, often without warning. They talked about crusting and leaking fluid, and infections can develop if germs enter your body through broken skin. Okay, it's like, this is the Academy of Dermatology statement. It's like, wait a minute, it's not, don't we know, colonization, impact on antimicrobial peptides. It says, for many children, atopic dermatitis improves or goes away without time. And in the therapy section, there was great emphasis on antihistamines, Coltar, which was a standard therapy. And so it's amazing how the field moves, and it moves very quickly, although when it's being done in steps or increments, you may not notice that it's happening that way. And the part on systemic therapy was just so markedly outdated. One of the challenges we have is I believe we need to establish better understanding of eczema amongst our general physicians in training and other healthcare practitioners in training. But it's hard. So when we do training for medical students, we recognize that most of their training still is overemphasizing inpatient management of disease. And while we do have inpatient atopic dermatitis patients, it's the exception rather than the rule. They have minimal time to learn dermatologic diseases, and much of the training comes in a small segment in their primary care rotations. So we have to do better to influence them. And then when they're in primary care training, it appears that the increased or changing knowledge in eczema hasn't translated through. So the knowledge amongst primary care practitioners and pediatricians, I think it's better than it used to be, but it's still limited, and the comfort level with even basics of the care of atopic dermatitis and its differential diagnosis is quite high. So there's still a lot of atopic dermatitis that's treated for scabies multiple times. So there's work to be done in terms of training. There's challenges even amongst the training of our specialists. So in the United States, for instance, in dermatology, what's very popular is Mohs surgery or cosmetic dermatology as part of the field in dermatology that didn't exist, but probably takes 20 to 30% of the activity of most dermatologists. So as compared to medical dermatology, these aspects of surgical and or aesthetic dermatology, which are important to our patients, take away necessarily from them trying to learn as much as they can about atopic dermatitis. And allergists have, there are more allergists who are engaged in our centers based for atopic dermatitis, but there are many general allergists where that's not part of where they make their living. And there are other aspects that they're more interested in, such as urticaria, with spontaneous urticaria being a disease state that's been highlighted by new therapies. And then a challenge that we have in consensus building is that we have different aspects of physicians, right? The primary care, the dermatologist, and the allergist. But we're also up against, Dr. Google, and the families come in, and if you, every now and then I do my searches online to see what comes up for atopic eczema or atopic dermatitis, or worse, if I go to TikTok, it ruins my day because number one, I spend 20 minutes clicking and going, this is terrible. And with interdisciplinary care, it's easy to have mixed messages to patients. So I think part of the precept that I learned back in the early meetings that were set up by this group was this concept of having messaging that's consistent across the spectrum of care. But we still know in many places there are parallel visits between a dermatologist and an allergist and a specialist, and patients get mixed messages. So we have work to do to have consensus amongst ourselves. It's hard to agree to algorithms regionally, nationally, or internationally, and we're in the midst of a rapid change in understanding and therapies. Now, another challenge that's come very far forward in the last few years is the recognition of the need for understanding the diversity of cultures and backgrounds, and this is across the whole spectrum: patients, families, and healthcare practitioners. And it's one of the challenges. Many of us live in communities with very diverse patients from many different cultural backgrounds. There are so many families who've been relocated from other countries, and we have to always remind ourselves that the way they look at us might be different. And this is something that's hard to do, especially because I'm still the center of the universe in my day, every day, right? Even though I'm trying to not be, I'm trying to make it the center, but I'm in charge of my activities for the day, and it's hard to be, even with a broad mind, to try to recognize some of the challenges that we have there. And I think we have opportunities as well as challenges because of the incredible changes that are happening in the field. So at the AAD meeting, we counted up the new, not including general sessions on eczema, just the new data presentations or new posters, and there were 96 at the March meeting. And I went through May of 22, just the English literature. So we were leaving much of the world behind inappropriately, but using PubMed English literature, it's 242 articles a month. So if you want to keep up every day, you have to read your 6 to 9 articles, depending on the day. It's really rather shocking. So I'm now going to take a digression and was asked to sort of, okay, so what's happening in the field, what's new? And this will be the quickest version of this, because it's basically just to go, oh yeah, that's right. There's a lot of stuff that's happening. We have, and of course I start off with trying not to be too me-centric, but I'm going to be US-centric because we're getting many of the drugs sooner. The variability of how they will be approved in other countries is, we know, in some cases right at the same time. Just like I noticed the movie theater two blocks from here has the same films, Jurassic Park, another version, and some drugs everyone gets at the same time, and others may never get approved because the healthcare systems are also different in terms of what they reimburse. But we have two new topical agents. with non-steroidals being developed, several just about to be approved in the United States, one approved, new biologics and small molecules, new indications and age indications. That's some of the major changes that we're going to have to deal with in the field. And then we also have, what I'm not going to discuss, is we have new data on comorbidities. And in the last decade, we have really learned about a set of issues beyond our traditional allergic comorbidities that we have to build into our decision tree on how we manage patients, and we have to communicate, or should communicate, those to patients and families. So just as a quick check, I figured we, as people who are teaching people about eczema, should know what different drugs are. So I just listed 5 relatively new drugs and try to match up what they are: topical ruxolitinib, topical tapinarof, topical roflumilast, topical crisaborole, and topical delgocitinib, and how would you categorize them? So topical ruxolitinib is the first topical JAK inhibitor that was approved in the US, following one that was approved in Japan. It is predominantly a JAK1/2 inhibitor. Tapinarof is a novel mechanism of action. It's an aryl hydrocarbon receptor agonist. Roflumilast is a very potent PDE4 inhibitor, which would be joining crisaborole as a PDE4 inhibitor. And topical delgocitinib is considered a pan-JAK inhibitor, not approved in the US, being developed for hand eczema and atopic dermatitis, and approved in Japan in different formulations. So this is not including another set that may be in development, but what's common is that these are anti-inflammatories and non-steroids. And they have different sensibility. Now, I will state that in the United States, you probably will not be seeing companies allowed to talk about relative JAK selectivity. They'll just say they're JAK inhibitors, but you probably won't hear that baricitinib is a JAK1/2 as compared to upadacitinib, which is a JAK1, because it's known that at different dosing, you start to lose the selectivity of that. And bonus questions, which are fine for infants, children, and adolescents, and it ranges. So topical ruxolitinib, our new one, is approved, but only in adults. In 12-year-old and higher. So, topical tapinarof is not yet approved for eczema. It just got approved for psoriasis in the United States. In psoriasis, it's approved to 12, but it's being studied in young children. So topical ruxolitinib seems to be quite potent. In phase 2 trials, it seemed to be different in that there was very, very little stinging and burning associated with it. In 8 weeks, you see 62% of people make an EASI 75, 53% clear to almost clear. So in 8 weeks, it's not as potent as a super potent topical corticosteroid, but it's not a steroid with a very reasonable rate of clearance. No evidence, a very rapid impact on itch. The upper right graph shows that within hours you have a marked change in itch with it topically. From a side effect profile, there have been concerns raised, and so there's a limit of not using it in more than 20% of the body surface area. It has a 6% bioavailability. And so what that means is if you put it on someone with 40 to 50% of body surface, you'd probably be at oral levels of ruxolitinib, a drug that's used for myelofibrosis and other, more significant conditions. And even though the safety data in topical use looked very reassuring without changes in blood levels, in the United States, they gave it a safety warning that is remarkably consistent, basically hearkening to problems with oral JAK inhibitors and saying that there's risks of major cardiac events, serious infections, zoster, and thrombosis, even though these were not seen. There was one case of thrombosis in the extended study, which was not considered to be attributed to the drug. Tapinarof, I'm just going to mention the ones because they're just well along the way. Tapinarof was just approved for psoriasis. There's very little systemic absorption. It's a novel pathway. It seems to have efficacy for atopic dermatitis. The studies are being done, finishing up in children ages 2 and older. Roflumilast is a phosphodiesterase DE4 inhibitor that appears to be much more potent as a molecule than crisaborole. In the United States, it's also being developed for psoriasis and a foam version for seborrheic dermatitis, but something I think could be very helpful potentially for scalp atopic dermatitis as well. And then we know that our biologics have expanded beyond dupilumab. Tralokinumab has been approved as an IL-13 blocker. Lebrikizumab, a different IL-13 blocker, just had its core data in phase 3 studies presented at the Academy of Dermatology. And even reading the data, I can't tell you, is it stronger than dupilumab or around the same as dupilumab? Because there's issues with the data, and these haven't been published yet. These are presented data, but again, it's a diversity in biologics. Dupilumab itself, I think, has one of the major changes that we have to deal with in the field. The extended labeling we just got a week and a half ago, down to 6 months of age. Now, I am very happy that in younger children we will have access to this drug, but I want you to know that the amount of young children who were in the study, 6 months of age to 2 years of age, were 11. So there were only 11 children who were treated with the drug in the study, and it's approved to that age. So here, my job is to interpret information and work with patients to understand the information. I don't have enough information, so the risk-benefit and discussions will be variable over time. And this drug has also been approved in asthma down to age 6. It got approved for eosinophilic esophagitis, and they've completed studies for prurigo nodularis. The relatively new kids on the block are our JAK inhibitors, abrocitinib, upadacitinib, and baricitinib. Different histories. Abrocitinib didn't exist before as a medicine, first for atopic dermatitis, UPA and baricitinib with other indications. There's variability in terms of the ages around the world that these are approved for. They have profound efficacy and speed of response. I'm not going to go through what the EASI scores are, but they're very rapid for itch and more patients who can make it to being clear with this drug. But it definitely has different safety issues with concerns about thrombosis, needing to avoid pregnancy, being aware of history of cardiac events, concern about serious infections, which is something we see as a differentiation from some of the biologic agents, as well as some common adverse events, not necessarily toxicities, with headache and acne and nausea being issues that are pretty common with its initiation, and a requirement for blood monitoring. And there is a whole set of other products that are well along the way, IL-13 blockers, a novel IL-14 alpha, a CCR4 inhibitor. There are 2 OX40-based products that have long duration. I don't expect you to remember these, but the point is, realize that we're doing our daily work, taking care of patients, but the system is in place that's bringing new drugs that we have to figure out, once they're approved, how we incorporate them in our regimens of care for patients. Personal experience, before I finish up and hand it over to Sebastian, that have impacted my sense of the challenge that we have with therapeutic education. I have enjoyed a great relationship with my pediatric colleagues, and regionally there's a group of around 200 pediatricians, and we were able to do an initiative where they all had a core training in atopic dermatitis, and as part of the trade-off for that, we built in a system where it'd be easier for them to prescribe standard medication. In the electronic medical record, they could do a single click and would get a set of medicines for the patients with a customized care plan. And we also built a volume calculator where if they estimate the body surface area of the patient and the age, It tells them how many grams per week are to be used for either QD or BID application. So when the patient goes home, they might know that their 80-gram tube should be utilized completely in 3 weeks of therapy if it's localized disease, rather than an indeterminate volume. And then in our multidisciplinary atopic dermatitis program, I've seen both successes and our limitations. This is team-based care with allergy. We definitely have more unified messaging. We've shown that we've improved outcomes in the patients who come to clinic. The patients are pleased with their knowledge base, and we have standardized methods for this clinic, but we haven't necessarily expanded that to the rest. I have 6 other pediatric dermatologists and 5 other advanced practitioners, and some of them use the materials from the specialty clinic and others don't. So the training modules are well received by the patients, but they haven't necessarily been utilized outside of that center. As I mentioned yesterday, one of the workshops, I've learned that the attention to detail of, for instance, allergy issues in patients with atopic dermatitis, even if it doesn't impact on their eczema at all, markedly changes the patient and, in our case, families' perspective, because they get a sense of us taking care of the whole thing of the patients. And we've been good at establishing consensus within the specialties, but limitations is the learnings necessarily haven't been adopted even by our own specialty clinics. So I think there are opportunities for the community as we try to figure out our consistency of clinical responses with evolving medications. The good news is that our abilities across the world to bring profound impact onto the disease and minimize the disease impact on individuals and families is markedly different than it was even the last time that we met together in Athens. So with that, thank you for the honor to be part of this incredible meeting. As people get to travel again, please take an opportunity to come visit us in San Diego. And I thank Jean-Francois, and I thank the foundation for including me.